Buxton is really a master clinician, a lot of experience. He was, I think he did all of his training at Penn. He did all of his training at University of Pennsylvania, and then stayed there together with Mark Josephson for years. And then they moved. And I think Al first moved to Brown.
First
Temple.
Temple. Children kept me in Philadelphia for a few years.
But I remember you were at Brown for a number of years. That's where Gideon joined. And then he moved from Brown to Boston, which is an easy and short move. But that's where he is right now, at Harvard and Beth Israel Deaconess Medical Center, and doing beautiful clinical research in cardiac electrophysiology. And so, welcome.
Thank you very much. This has been an amazing day for me, and I really appreciate it. I hope I learned, I think, a lot more, hopefully, from you guys, so I can share with you. The most important disclosure I have is that the hard work here wasn't done by me. It was done by a number of colleagues that I'll mention during this talk. But we've had an awful lot of fun doing this, and I want to, there'll be some, let me sit down here so I can work this thing. There'll be several points that I want to make, but the bottom line message that I want to try and convey is the importance of bringing and keeping the physiology in electrophysiology if we're going to do the best kind of work. And I'll show you, hopefully, what I mean. So if we talk about trying to fix people that have ventricular tachycardia, fix their arrhythmia, most people would acknowledge that it's preferable, the best results probably come when we have people whose ventricular tachycardia is hemodynamically stable enough that we can perform activation mapping and do a variety of pace maneuvers that validate our activation mapping as showing what are the requisite parts of the circuit. But as anybody who does this knows, a minority of the patients we see today remain stable enough to do all the maneuvers and mapping that we like to do. So people have resorted to what's been called substrate mapping. And therein lies the rub. What is the substrate means different things to different people depending on where you practice. And as you see on this slide, a number of different methods have been promoted as revealing the substrate. The problem is that the substrate for VT, and I want to restrict my comments to post-infarct VT, monomorphic VT, it's not just based on anatomy. It's a structural, but we're talking about a functional abnormality. We're not talking about a rhythm that people live in all the time. So there has to be more than the just structure and anatomy that is required to initiate and maintain what we know in most cases is a reentrant arrhythmia. So let's first talk about limitations of structure alone. The MRI. Here I show you images from a man who was referred for a primary prevention ICD. You can see a significant area of delayed enhancement, correlating with a big anteroseptal infarct. And yet, electrophysiologic testing, which admittedly may not reveal all ventricular tachycardias that people develop, but it's fairly well established as being quite sensitive. There was no inducible VT, in spite of this huge scar. Here's another man who presented after having been resuscitated from sustained VT, and look at the size of the scar here, much smaller. And this person's ejection fraction was within the normal range. And then, take a look at this image, which is from a 55-year-old woman who had presented with sustained VT about 4 months after an inferior infarct. And you can see that she has a fairly discrete inferior scar here. And what do you think she had when we studied her? We couldn't induce a thing. And let me show you the first episode of her ventricular tachycardia here. And she had a total of 4 more episodes over the next year and a half. Oops. Let me go back to that. So what's wrong with this picture? When we look at this VT and this VT, another episode of her VT, and this MRI image. Well, the problem is that this MRI image shows an inferior scar. And these VTs, which both have the same morphology, they have nothing to do with this inferior scar. Okay? And as I said, it was non-inducible. It turned out this is probably, I think, a triggered rhythm. What we did was to tell her, when we studied her twice, to call us the instant she had another episode, and we'd bring her into the lab, and we'd map her during her spontaneous VT, which we did. And as you might suspect, we mapped it and ablated it at the left ventricular outflow tract. So for some reason, this lady who never had VT before her infarct started getting monomorphic VT after the infarct. And so not all VT that we see after infarctions is reentrant, obviously, and not all of it is directly, at least apparently, related to the infarct. So that's part of the problem with using just anatomic information. And I think you'd have to conclude from observations like this and other people that there's a lot more to the substrate for VT than we can detect just from anatomic types of imaging.
This lady, how many years or how close to the MI did she develop the
Her first episode occurred 4 months after her infarct.
only 4 months?
And over, this was back
Because
in,
one possibility is that it caused more stretch on the
Sure.
RVOT.
yeah. It's still, I mean, that's what I
4
assume
months
something
is enough
happened.
for remodeling of the RVOT.
Yeah, LVO2. Yeah.
LVOTs.
Yeah. Strange, but this happens. What about voltage, which is probably one of the most common, widely used methods for, quote, equating scar? So we know that, we think, low voltage, when we map it, at least on the endocardium, correlates with scar, and we assume that that low voltage represents slowed conduction, which is part of the substrate for reentry. And the usual definition of low voltage is local electrograms less than 1.5 millivolts. And there are a number of our colleagues around the country and around the world that seek to fix these VTs by trying to ablate all of these low voltage areas. So what's the data that supports this idea? So here is a study, an image from a swine model that my colleague Elad Anker has developed, an anterior infarct model, studied with high resolution mapping using the Arrhythmia system with very small electrodes, high resolution, and you can see here that in this image on the left, here is where the VT circuit was mapped. And there's a common isthmus, and then activation spreads around here. And we'll see more of these. I have a video of similar VTs later on. But you see that it's a relatively small area of scar, small area of the myocardium is involved in this scar. On the right is the area that would correlate with scar using conventional voltage cutoff criteria. A huge area of scar there. And something's wrong. I mean, obviously not all the low voltage area is necessary to entail an arrhythmic circuit here, a reentry circuit. And you see here data from 10 swine. We're now up to 16 swine studied with about 24 tachycardias, and also integrating it with clinical data in patients with prior infarcts and about an average of 2 monomorphic VTs mapped per patient. So here's another example of what was mapped. This is one of the swine with anterior infarction and inducible VT. And you see here the common channel going out around like this, and then the entrance into the reentrance circuit here. And look at the disparity between the voltage map using the conventional cutoff here for very low voltage of 0.5 millivolts. If you readjust your sensitivity and you cut down to 0.1 millivolt, look at the difference in very low amplitude circuits. And there's a theme that I'm going to make here that suggests that the voltage that you see correlates to some extent with the various components in the circuit. In the isthmus area, the voltage on average is less than 0.5 millivolts. But the very low amplitude signals are seen where there's marked curvature, what we believe is curvature based on the our interpretation of the electrograms, at the entrance as well as at the exit from the sites. It's these areas with very low voltage that at the turnaround that have the lowest areas of voltage that we've come to refer to as the critical area for initiation and maintenance of the reentry. Another example here in another swine with the circuit that was defined here and how much more by conventional mapping low voltage there is. And if you again look at 1/10 of a millivolt as the cutoff for very low voltage, much less of very low voltage. And the areas where the isthmus participates is again about 0.5 or slightly lower millivolts, and the turnaround in this area at the entrance to the isthmus is where the really low voltage area is. But notice that there's a lot of other very low voltage areas in the LV here. And if you look at the data from the 16 swine that Gilad mapped with an abundance of local electrograms, you see that voltage less than 1.5 millivolts has moderate sensitivity, okay? Moderate specificity. The positive predictive value, the areas with this that seem to be part of the critical, the common channel or the isthmus, have pretty low positive predictive value. If you look at the electrogram characteristics during sinus rhythm, again, there's the sensitivity of these various characteristics of abnormal electrograms, and the specificity, it's not bad, especially for isolated late potentials, but it's not something that you could base, I think, reliably and say, if we take somebody whose VT is hemodynamically stable and we just pay attention to these abnormal electrograms or to the low voltage areas, that we have confidence that we're going to fix that person's tachycardia. Let's go back a second and talk a little bit about what are we recording with our electrodes and the limitations of this. So these are data from my colleague John Miller when we were at University of Pennsylvania and operating on patients with VT in the 1970s and 1980s. And John did a really interesting experiment where he took a little plaque with pretty closely spaced wires and small area, and he took this plaque and placed it into the left ventricle after the left ventricle had been opened through an aneurysm in the operating room, before we did any mapping or resection. And I'll show you on the next slide characteristics of the electrograms recorded with this plaque before the resection, after the resection, and then placing the resected tissue back on the endocardium in the same spot, with sutures used to mark the same spot, so you could get back to the same area. And remember, these were not the resolution of the mapping systems that we have today. But pre-resection, no surprise, a lot of areas in this aneurysm of the patient with VT of delayed activity here, late potentials. After resection, look at the absence of the late potentials as well as the increase in the voltage recorded locally with the same electrodes. And then if you place that the area of resected tissue back in the same area, you've got kind of an insulation effect there, obviously, because it's not viable tissue, it's not perfused any longer. And you have, again, much lower amplitude electrograms. This is, I think, really interesting. It implies that, remember that when we resected these areas that contributed to VT in the OR, it was resecting about 2 millimeters at most depth off the endocardium. And it implies that what you're recording with these types of bipolar electrograms is very shallow tissue that has an insulating or an effect of counterbalancing underlying more normal tissue, as you see after the endocardium that seemed to correlate with the VT circuit was resected. Other problems with just using voltage is that what you see as far as the local amplitude of electrograms is influenced by a number of other factors, not just the electrode itself, but if you take a standard ablation catheter and you look at the area of low voltage that's reported, you see a fairly extensive low voltage area in this person. But when you take Pentarray, which is a catheter that has much smaller electrodes, more closely spaced, now you see that there is much smaller area and much more heterogeneous area of very low voltage. So local electrode size will affect the characteristics of the voltage that you record. And here's another example. That's even more extreme. This is Eran Leshem, one of our fellows, in a pig model here, mapping with an experimental catheter that has 3 very small electrodes embedded in the tip, here, here, and here. I hope that should project fairly well. With the distance between electrodes, as you see here, under 2 millimeters. And let's just go back here. So you're going to see on the next slide 3 areas sampled from this area of infarction. And the remarkable thing is that with the standard ablation electrode, which is shown here, we have a very low amplitude signal in each of these sites, site 1, 2, and 3. With the very small electrodes, you see much larger local signals, presumably because you don't have canceling of forces by the much larger field that's recorded by the large electrode. And so what's low voltage? Well, it depends on how you're recording it. Here's another example. This is from Rod Tung and the group at UCLA. Very similar findings, where if you use, illustrating another factor that varies here, the wavefront of activation. So compare the area of low voltage when right ventricular pacing is performed versus the area of low voltage during sinus rhythm. And there's a great deal of discordance between what's low voltage depending on the wavefront of activation. And an interesting example also from that study is the fact that in this patient here was where they mapped VT to, at this red dot here, typical ablation lesion. And during RV pacing, this site that correlated with where they were able to terminate VT appears in an area that has normal voltage, whereas when he did LV pacing, different wavefront of activation, now it's in an area of much lower voltage. So the wavefront of activation influences the voltage that you record. So these types of observations suggest to us that low voltage is fairly sensitive. It's certainly not specific. It's not 100% sensitive, obviously. You can't remove all the scar that you detect that has very low voltage. And endocardial recordings, bipolar recordings that we make, represent fairly localized activity, obviously depending on what size electrodes you're using. Voltage is measured, that we measure is influenced by the electrode property. Also, what we didn't show an example of here is how the catheter angle with the endocardium can influence the voltage that you see, and the activation wavefront influences the voltage that you measure. So we don't think that just basing ablation on voltage is likely to be very productive. Another technique that's often used is pace mapping. And I'm not going to show examples of pace mapping, but the problem with pace mapping in a patient who has SCAR is that you're trying to replicate the ECG morphology with your pacing, the ECG morphology of the VT. And that assumes that the barriers, when you're in an area of SCAR where you think the VT is likely to originate, that assumes that you've got fixed barriers for activation. But we know from multiple experiments that the barriers around which reentry circuits circulate are, to a large extent, they're functional. They're not fixed. So that's why I think often in this situation, as opposed to pace mapping when we're ablating PVCs or VT in patients with structurally normal hearts, it's much more difficult to replicate the QRS morphology in the infarcted heart. So what about using abnormal electrograms as characteristics? Electrograms that have multiple components and are broad fractionation and multiple late potentials. Well, several groups have looked at this, and this is, I think, much more appealing because it's starting to get at the physiology. We're stressing the system, and we know that in most of these post-infarct monomorphic VT patients, programmed stimulation will allow us to induce the tachycardia, and so presumably that's causing changes in the local physiology, local conduction, and refractoriness that are responsible. The problem is that most of the studies that have been done have shown local electrogram abnormalities that you can exacerbate by pacing, either straight pacing or premature beats, as you see in this publication here from Spain, one of the groups in Barcelona, or this publication from the group in Toronto, where, again, they're delivering multiple premature beats and looking for electrograms that have components that delay. The problem there is they've not shown that these areas that show delay are part of the reentrant VT circuit. We know that if we deliver premature stimuli in areas of infarction, there are lots of areas that will behave showing decremental conduction. And I think this is better than just using a static late potential or low voltage, but it's still probably not ideal. And you can be skeptical and you can say, well, your physiology is fine now, but here are results from a multi-center study that Andrea Natali and collaborators published, where they compared the standard clinical VT ablation techniques, meaning mapping and performing entrainment mapping and pace mapping, anything that the investigators wanted to do, versus just trying to ablate all the low voltage areas, and low voltage including areas with late potentials and fractionated electrograms. And you can see that over a 1-year follow-up in this roughly 110 patient study, that the people that had the presumably clinical VT type of mapping and approach it more substrate, detecting the physiology, didn't do as well as the people where they ablated every possible visible abnormal electrogram. So does that mean we should just give up and just ablate the hell out of every low area? Well, I think not. And the reason is if survival isn't free of VT isn't as good using these standard mapping approaches compared to what's called homogenization, trying to ablate every abnormal electrogram, it really suggests that these markers that we're using aren't right, that they're not as specific as we would think they are. So where does that leave us? And why are these ablation results suboptimal? And let me not read through all of these because I think I've alluded to all of these things except for the last point, which we're going to save till the end of the talk, where I raise some interesting suggestions. What can we do to improve our mapping to detect the substrate, and especially the substrate in people with unstable VTs? So here's, again, one of the swine VTs. And here now we have the video. So you can see, you saw this same VT earlier in the talk. And you can see how the pattern of activation is progressing with the entrance of the arrhythmia down at the bottom here, and it's progressing up. And you can see the isthmus, just use this, the isthmus here, and the turnaround points. And what Elad and colleagues have done is to measure various parameters of, and I keep getting on him because he likes to talk about conduction velocities, and I think we have to recognize limitations that we really are measuring activation times, and because it's a two-dimensional map. We don't know for sure that we're really measuring the exact distance over which the electrogram's progressing. But it's probably a fairly reasonable surrogate. And again, once again, in another one of the pigs, the circuit here and the electrogram characteristics right at the area where it turns around, you can see that there's a very low amplitude electrogram here. If you look at the isthmus, you tend to see higher amplitude electrograms, and often two components, presumably one component from the middle, the common channel, and one component more distant, from remote on the other side of the area of block here. And the areas that are then local and further along may show still a little bit higher voltage here. Another circuit here, again, making the point about this was a very small, what we probably would consider a micro reentrant circuit. And it wasn't entirely obvious initially just what was going on when we analyzed these electrograms. Here's the area of low voltage, bipolar low voltage. Here is using a cutoff of just 1/10 of a millivolt instead of the 0.5 millivolts for very low voltage here. You see, again, much more heterogeneity, these very low voltage areas, which, as I said earlier, it seems to be that the lowest voltage areas are at the turnaround points of the circuit. And here again, a much smaller isthmus, the turnaround where the circuit seemed to be circulating the very low voltage area. Another example, here now showing what happens if we just use the sinus rhythm map, where there is a scar area here of low voltage, and how this changes in, again, the pig model during RV pacing. And what's interesting here is, give this some time here, because this is playing through, and take a look at what's happening. This area here is where the VT circuit was mapped to. Notice that even in RV pacing, not during VT, this same area showed a great deal of delay in activation. And you can see that also sometimes even during sinus rhythm, that the areas that seem to be, when you do this high resolution mapping, the critical areas of the turnaround and the isthmus are also activated with a great deal of delay during sinus rhythm. And in this case, there were two VTs mapped with two different axes that presumably represented different exit points, one going clockwise, one rotating counterclockwise, a line of lesions placed across what appeared to be the isthmus. No surprise, it rendered both of these VTs non-inducible. Here's a clinical example. This time it's going to be using the Cardo mapping system with the Pentaray small electrode catheter. So here's a patient that presented to us last spring with VT. He already had an ICD in place. You see we've got a left bundle branch block type morphology with a kind of an indeterminate axis, positive in 2, negative in 3.5, like you might expect with an inferior infarct. 3 VTs were induced in the lab, this one looking like the clinical VT, the spontaneous VT. Here you see transition from one VT to the other. And what's interesting is abnormal electrograms here stay fairly constant in spite of the transition from one VT to the other, implying, as we know, electrophysiologists know, that a lot of these VTs share a common isthmus and that you don't have to ablate multiple areas, not all the time, but often, in order to render different VTs non-inducible. The electrograms, with an electroanatomic map, during straight pacing and during premature beats, show, in the area here, show the fact that we can often see areas of increased, heterogeneously increased delayed activation, like you see here, compared to the drive, much more delay to this particular site here. You can also see sometimes block. Now look at these maps in a patient here with the S1 and the S2. Voltage doesn't change very much at all when you measure the local electrogram amplitudes during the drive and the premature beat. But the activation shows much more difference. During the drive here, there's a fairly large area of markedly delayed activation. When you deliver the S2, there's a much smaller area of delayed activation. Why? I suspect the S2 shows local block in some of these areas, and that's why they're not activated in a markedly delayed fashion. Here and here you can just see delineated the area of markedly delayed activation with the drive versus the premature beat. And this was fairly consistent, that the zone of maximal delay is smaller with extra stimuli. And here's an example where the extra stimulus produces local block in some of your electrograms here. Okay, and you can see also that the other electrograms recorded with the Pentaray catheter, they splay out. So there's differential conduction in this local area. And this is just making that same point, the same kind of thing. Differential conduction delay in local areas here. This local electrogram. And when you see you induce VT and you look at the local activation in these areas, often where you've got the turnaround, not only do you see a cascade of activation, implying that this is showing the pathway of activation, but at the turnarounds, you often see these markedly prolonged local activations. This is really hard to decipher in the lab, real time. And here, in this patient, is the standard activation map, okay, during VT. And I don't know about you, but looking at this activation time, it's pretty confusing. Here is an experimental map with software that's been developed by Elad, collaborated with the people at Biosense Webster. And what they've done is to use an algorithm that develops vectors to show the local progression of activation. And don't ask me to explain how it works. But what you can see is now, whereas this is pretty confusing, this algorithm shows, at least if you believe it and that it's real, that you have a circuit here in one of these areas of low voltage, delayed activation rather, that you've got quite a bit of rotation around what appears to be a very small circuit here, with most of this area being passive here. So this is one way that going forward we may be able to do better mapping by doing this functional type of analysis. Because what you see when you look at the electrograms in this area here during sinus rhythm, again, talking about applying this type of thing to hemodynamically unstable VTs, is the idea that the electrograms around this area show delayed activation during sinus and very long electrogram duration, both during sinus as well as obviously during the VT. There we go. Okay. So here is the pentarade catheter placed in the same patient at this anchor point here. And what you see is, as I was saying a minute ago, markedly delayed activation recorded between the electrograms, this little circle here, between these electrograms, where the circuit seemed to be rotating around. And so it suggests that we may be able to see in some of these circuits characteristics that are identifying the critical areas that are subject to rotation because of markedly slowed conduction characteristics. You can see local block when you do pacing and in program stimulation. You see that this late component here that appears during straight pacing, it is blocked. And yet, in spite of that block, you have VT induced. And this area that showed local block, it doesn't look very interesting. There's nothing exciting about this local electrogram that would say, oh, this is part of the circuit. So again, it illustrates how complex these circuits, and just seeing areas of block doesn't mean that that area is going to be critical for the VT. Another example here of how when you're mapping the VT, how the Isthmus electrogram with a standard ablation catheter doesn't look like there's local delayed activity, but there's nothing especially remarkable about this electrogram. When you look at the local sites, and this is the same thing again, the bottom line from these studies suggested that in these swine mapped with the Orion, that the bipolar electrograms, the filtering like you see here, also unipolar electrograms, and what has been calculated is the mapping resolution, that you can see, again, the very low voltage you see at the sites where there's turnaround. And here is the summary from this that we've been showing earlier, that in the area where there appeared to be the maximum curvature coming right around at the entrance to the common isthmus, that's the site where there was the most delay in activation, where you saw the electrograms and the isochrones really bunched up. And these are complex electrograms, and I want to show you here how useful recording unipolar electrograms together with the bipolar electrograms can help to decipher the activation, what's going on. So look at the bottom here. This is a bipolar electrogram. And both of these components here look like they're near field components. They're pretty rapid. There's a second component that has a larger amplitude, but that doesn't necessarily mean that that's the local activation. How do you decide what's local activation? Well, in this area of an infarct here, you can see that there were 4 sequential electrodes on this, and these are small electrodes, on one of the splines lying across the area of infarction and VT. When you look at the unipolar electrograms, the top 4 tracings there, recorded from each of these electrodes, you notice, obviously, the unipolar electrogram, the most rapid downstroke is our gold standard for local activation. And you notice where the most rapid downstroke is on these electrograms. And you notice that they all occur at the same time. So if they all occur at the same time, obviously the wavefront must be coming from another place. They can't be, you can't have these 4 separate electrodes over here all be activated at the same time if this is the local activation. So it suggests that with the bipolar pair, it's actually this component of the electrogram that represents local activation and not this. And it's, I show you this to show how both bipolar electrogram interrogation may help your interpretation of the unipolar electrogram examination, may help you interpret some of these bipolar electrograms here. That otherwise, I don't know how you'd decide which is the real local activation type. Now here is the part of one of the maps that led us to think that it's the bunching up of electrodes and of electrograms, and that you can see the same types of conduction abnormalities during sinus or sometimes during RV pacing that you see during VT. So here is a VT, and you can see, I don't think we have a video, we don't have a video on this one. Here's the VT circuit. Here's the entrance to the circuit, the common channel, the exit going around here. When you look at the sinus rhythm map, you can see that the activation, here's the activation wavefront, coming here, coming here. There's delayed activation, markedly delayed, down at this lower area here that appeared to be the entrance into the common channel during the ventricular tachycardia. And here you can see delayed, markedly delayed activation during the sinus rhythm. And there's bunching up, it's hard to see on here, but there's bunching up of the isochrones, markedly slowed conduction down at the entrance to the common channel here. And this, I think, may carry us a step further than just looking at areas that have delayed activation either during sinus or pacing from the RV or the LV, or even delivering premature beats, to look for areas that are subject to delayed activation. This may actually give us, hopefully, more promise for unstable VTs, detecting the areas that are critical for the circuits just during sinus rhythm or pacing. This is further work on that. This is work that was presented by one of our fellows last year at the Heart Rhythm Week. And this is an animal with one of the swine with inducible VT. Here is activation during atrial pacing, during RV extra stimulation, and during VT. And the idea here is that where the VT was, the critical instance, which was a very small reentrant circuit in this example, correlated with the area where the isochrones really bunched up, both during atrial pacing in this case, as well as during RV pacing. This was the zone of maximal deceleration, you call it, or the steepest gradient of activation. And interestingly, when you look at, and again, using conduction velocity, acknowledging that we're dealing with a three-dimensional structure and we're just looking at 2 dimensions. But the amount of conduction velocity, the degree of conduction velocity is markedly slower when you give extra stimuli. The gradient of conduction velocity, that is how much slowing within a small area there was, is much greater here. In the swine that had VT, look at the numbers here for the conduction velocity in these animals. If you compare them to the swine that didn't have VT, there's much less discrepancy, much less slowing of conduction in the swine without inducible VT, suggesting that this, again, this bunching up of electrograms, the area with a very dense area of markedly slowed and delayed activation, even during sinus rhythm, may be more helpful than just looking at isolated electrograms. So this is, we hope, some promise for the future for more complex analysis. But it's obviously, this is complicated because it involves more than just looking at isolated electrograms. It means analyzing the composite of activation during a pacing maneuver or during sinus rhythm. If you look at this though, and here are the data on the top are the same as I showed you in the table in the earlier slide. And now if you look at the amount of conduction slowing, if you look at sensitivity for a correlation with the critical parts of the VT circuit, the entrance into the common channel and the common channel, you see that where you get here both the common channel and the criteria at the critical turnaround, marked conduction velocity slowing, either more than 50% or more than 75%, has increased our sensitivity without much change in specificity, and it greatly increases the positive predictive value of ability to identify these, what we suspect are the critical elements in these reentrant circuits. And you see those data highlighted there. So let me summarize by saying it looks like from particularly the swine data and from also some early human data that the isthmuses occur at, and that's the common channel, voltage that's less than 0.5 millivolts. And you don't need to identify a target tissue that's between 0.5 and 1.5 millivolts has been done conventionally. The areas with the turnaround show the lowest voltage, and those are typically at or less than 0.1 millivolt. The isthmuses, they seem to be functional, not fixed areas of block, because when you look at activation goes through them during sinus, during pacing. This is no surprise. This was shown years ago by Andy Witt, his canine model of post-infarct VT. The relationship voltage and circuits is complex, and you can get a large voltage by very small electrodes or by healthy tissue. The voltage that you record is going to be affected by multiple factors that we reviewed earlier. And finally, very slow conduction, we know, is not sufficient by itself to initiate and maintain reentry. We need to have also disparities in activation. And that's an underexplored area as yet in these experiments. Now, let me show you one other factor that especially pertains to your group here, and that is how good is the RF that we deliver from catheters at ablating post-infarct or scarred VT in the setting of non-ischemic myopathy. I want to tell you a story. Back in 1995, when John Miller and I were at Temple back then had a very busy transplant program. We were the second busiest transplant program in the country. And there were a lot of recipient hearts that were explanted in patients getting transplants. And John was able to get about 5 of these hearts immediately after they'd be removed from the chest, kept them in a 37-degree water bath, and we took ablation catheters by hand in a bowl, pretty crude experiment, and we applied RF. And these were not the ablation catheters that we have today. They weren't irrigated catheters. But we could hold them, and when you delivered RF in areas that had normal-looking myocardium, you could create very nice lesions that were grossly visible. When we applied the RF to the areas of scar on the endocardium, we did very little damage. You could barely see it. And this study was never written up, but in the swine model, Michael Barkagan, one of our fellows, has replicated this, and you see the histology here. Here is a typical lesion in healthy-looking myocardia with the typical crater, and you can see the typical types of changes histopathologically. And these were done with catheters in vivo, and then the hearts removed. And the RF was delivered, obviously, in healthy-looking areas as well as in the areas of scar. When you looked at the scar, you couldn't find any discrete lesions, in spite of obviously having delivered RF with catheters in the areas with the abnormal electrograms. So the limitation is that, for whatever reason, I think our RF that we deliver through catheters has limited efficacy in areas that are very scarred. And the reason for that, I don't understand. I don't know. I'm sure Yoram could explain his physics. But the fact is, this suggests that maybe we should be looking at other modalities for ablation in some of these patients. And that obviously has a lot of relevance to the work you folks have been doing here recently. So let me leave you, first of all, I have to acknowledge not only my current colleagues, but the work of Mark Josephson, who was the person who initiated and drove initially the swine experiments and enabled Elad to set up the lab that we have now, and who was a great mentor for many of us here. Also Andre Kleber, who has helped with interpretation of these studies. These are fellows in our lab, and this is one of our technicians who now has gone back to the University of Pennsylvania. Let me leave you with one final thought. I'm kind of a wood guy. I have a thing for making things out of wood, wooden boats, stuff like that. And I leave you with this quote from Frank Lloyd Wright, who said, we may use wood with intelligence only if we understand wood, meaning the properties of wood. Well, I would paraphrase that and say we can ablate, try and fix people with VT and other arrhythmias only with some degree of intelligence if we understand the mechanisms underlying it. And it takes us back to the importance of physiology and mechanisms, and not just jumping at things that may, at first glance, sound good and on a superficial look may seem logical. So thank you very much.
Thank you very much, Al, for this very thoughtful presentation. Brings up a lot of important issues. Some of them we've dealt with and struggled with for many years, but still So I don't know if anybody has, but one interesting thought before. So you showed the areas of entry, or the pivot. We used to call it pivot areas. But they call it turnaround.
Yeah.
The pivot area. So the understanding is that when you have the pivoting wavefront, there is a mismatch of source and sink, because there's a small, if you have high curvature and you have a more source feeding into a large sink.
Yeah.
And that will compromise exciting current.
Right.
And therefore, any kind of structural inhomogeneities that you have will resurface, and you'll start seeing all these fractionations and slow conduction.
Right.
Because your excitability is compromised. Then you show that the same areas that show this during the reentry, VT, they also show this property during sinus rhythm.
How
And
strange.
that's interesting because, you know, it's globally, there is no curvature that you can see because your activation sequence now is not reentry.
Right.
But you still see these properties, which tells me that there is excitability, there is compromise on a substrate that is already, you know, structurally abnormal, even if you don't have this global rotation. So there has to be something on the microscopic scale, on the cellular scale,
Right.
that you don't see with this mapping techniques, because gap junction uncoupling, excitability, and the maintenance of a waveform that we see globally occurs really on a microscopic cellular scale.
Yeah.
So there has to be something on that level there. It's already compromised because it shows even when you don't have global curvature.
That's a big
So
challenge.
that would be interesting to find out, and the way to do it is probably with in the swines. If a lab could do some optical mapping of the swines, that could help.
You mean in vitro, open up the hearts
Well,
to
the
enable optical mapping?
swine, yeah, in vitro.
Yeah. That's the part, all these swines, this work isn't finished yet, but all these swines get histology in Jeff's lab, from one of the pathologists there, as well as...
Histology again is global, but
Yeah.
if you could excise the tissue and base it from somewhere and do optical mapping on that piece.
Yeah, that would be really neat. The problem is, the maps are being done with the pigs intact, and then they're sacrificed. So you don't know, you can't, we don't yet have a way. It's similar to trying to map the VT and then leave a tag for RT.
Yeah.
How can you leave that tag to say, this is where we were, where we saw these electrograms? It was done, if you remember, in the OR with the surgical treatment of VT. Walden Harkin, the surgeon, for one of the studies, put stitches through where, and that went to Andy Witt's lab, and you could see, obviously, the twisted...
We need to go to a more microscopic scale, because the fact that, that's an important finding, the fact that you see the same properties.
I know.
When the global wavefront is not rotating, it's telling you that it's not because of the global wavefront being compromised by the rotation, but there is something on the microscopic scale. That by itself is an important statement. Now
Right.
the question is what?
Yeah. It was really surprising to me to see, because I thought, well, you're not going to see anything unless you start stressing the system. But it's interesting that there are abnormalities, local delays there, even sometimes during sinus rhythm. I don't think that explains every single one, but it's interesting.
It's something to explore on a smaller scale. I mean, I don't know how to do it, but maybe a lab knows.
We haven't come up with an idea yet. Yeah.
I'm not an electrophysiologist, I'm just a diagnostic cath guy. I have two questions. One is, do you think if you had information on the third dimension of how these electrical phenomena, wavefronts are moving, as opposed to just the two-dimensional stuff, that would help resolve some of the problems? I'm asking sort of in the Art Winfrey sense of the scroll waves and three-dimensional manifolds and so forth. Question one. And question two is as a diagnostic guy, whenever I do cardiac caths with fellows usually, and we accidentally fall into the LV with a right Judkins catheter or something, and the catheter's going tickle, 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 we'll do VTAC. And then you take it away, the VTAC stops. And so during all this mapping, you guys may know this. So when you do all this mapping stuff with catheters poking on, how come the whole thing isn't going crazy? I don't know the answer, I'm just asking.
The answer to your first question is, I think in some cases, we know now that not all VT has the circuit localized to the subendocardium, to the first few layers of cells. There are some where it seems to involve deeper layers and some subepicardium. So, but most of the action really seems to be within in most of these cases seems to be reachable with our catheter, reachable in the sense of reporting the interesting things with our catheter. So yes, I'm sure it would add more because I'm sure we would. It's got to be a three-dimensional type phenomenon, not just two. The trick is how to do that. As far as your second point, it's far easier to do a map in a patient with a big infarct and a dilated LV than a patient with idiopathic VT and a normal heart. And I think in part because if you have a dilated heart, your catheter has a lot more room to move when you maneuver it there. And because you've got a lot of scar, it tends not to, I guess, be as sensitive to movement because, we see that all the time when we move our catheters in normal people. If we're doing SVT ablations, they're very sensitive to it. And yeah, it's obviously all electrophysiologists recognize that phenomenon.
Don't you guys get arrhythmias of the catheters all the time?
Yeah, but it's as you
That's what we're
said.
talking about.
I think in those normal hearts, in those smaller chambers, in the hearts that have more myocardium that your catheter is touching, with the same contact force, you're more likely to get PVCs and arrhythmias from that, as opposed to if it's a diseased, thinned tissue. With the same contact force, you tend to not get spontaneous arrhythmias from
Less
that.
stress-activated channel.
I think so. I would have to say that it would be kind of a summed, the way to think about it would be some sort of summed event, that there's fewer of those channels underneath.
I probably don't see, diagnostic cath, I probably don't see the same ventricular geometry that you guys select for.
But it's still similar. We see it all the time. It slows the procedure down. I mean, when sometimes 30 or 70% of the ectopy we see is catheter induced. And so we're lucky, though, we've got an electrical signal from the thing that's causing it, so that helps us be able to sort out with timing, not to mention comparing the 12 leads to what we're looking for.
The other difference is that our nurses aren't yelling VVVVV every time there's we get a PVC or
Well, that's good, at least your nurses are watching. My nurses are on the phone when the patient's in attack. I don't know, we are not a defibrillated patient.
Yeah, but Shandro, your first question is important too, the three-dimensionality of the scar and thinking that through.
So you don't use plunge electrodes to map?
No.
Because that you would think, if you plunge electrode in myocardial,
It's been done.
There's a catheter that's available that has an extendable tip that Bill Stevenson is using to try to understand a little bit about. He's using it more to deliver deeper radiofrequency energy, but you can also record information from tip and depth with that. And Rod Tung in Chicago is doing a lot of nice simultaneous epicardial and endocardial maps.
Yeah.
So simultaneous at the same, you're really trying to get an idea of how much of a circuit might be confined to one or both or neither sometimes. And it's really provocative. It's the first time you're seeing that done in a routine sort of way. So I think we'll learn more about the three-dimensional components of the scar from that.
Okay, any other comments or questions? Well, thanks so much, really, for coming and for sharing all this new data with us.